So slight change in order based on our faculty reaching here. So Dr. Ritika will be starting on tackling regressions.
A very good morning. Can I just have... I'll be talking about regression and retreatments, when and how. I'd first be starting about the LASIK procedure and then moving on to the SMILE. The incidence of a regression and the requirement for retreatment with modern technology is lower than 3 to 5%. Early regression may happen within a year. It may be undercorrection or regression, and late regression can be seen at a later age. So I'll be discussing the pre-op examination, the timing and the methods of enhancement. What you must know is that you must have a follow-up serial workup of patients who show up with refractive error post-refractive surgery. The refraction should be stable for at least 3 months, topography stable for at least 3 months, with an optimum ocular surface and epithelial mapping, because you don't want the epithelial hyperplasia to be going on. It is also very important that sometimes you get late regression when a patient is about 45, 40. Then there is an element of lenticular myopia. So, and myopes develop earlier cataract. So even at the age of 40, do look that if there is a nuclear sclerosis coming in, don't go touch the cornea at that time. It is wise to have epithelial maps, because you know the epithelium tends to mask the effect of any irregularity. So you must know that the epithelial remodeling is stable before you're touching the cornea. And of course, there is an element of ectasia that can happen as a complication, which also manifests as a post-op refractive error, and that has a completely different line of treatment. And ectasia can happen even post-PRK and even post-SMILE, so it must be ruled out. To prevent the chances of regression, we have now normogram adjustments, better machines, and the possibility of combining extra procedures in patients with higher refractive error, though I am still on the fence about the science and the truth about the extra procedure. After a complete workup, I would just like to add that an ASOCT is sometimes very useful. It's actually all the time very useful, and the planes may be better seen in the earlier time. The later you stay, the planes may become fainter. So it is a good idea to do an anterior segment OCT in the first few weeks to know the planes in terms of the depth. The most commonly done technique for LASIK is a flap relift. You can mark the flap with a marker or a 30 gauge on the slit lamp, the flap edge, and gently lift the flap. It is quite easy to lift the flap, even multiple years after surgery. So you see drying the surface and just dimpling the edge. It is easier to lift microkeratome flaps than femto flaps. You must try to minimally disturb the epithelium, because the only great risk that you have in relifting a flap is the risk of epithelial ingrowth. So this is the flap lift that we are doing. This is a 10-year plus flap. Some studies have shown that the risk of epithelial ingrowth increases significantly after a 3-year-old flap. So then you can opt for a PRK procedure. However, there are disadvantages of PRK other than the chance of longer recovery. Haze is always higher in a retreatment. So even if you're correcting a small error, you will have to use MMC. And when you do a PRK, you've disturbed the epithelium. And epithelial remodeling starts in again, which again makes it a little unpredictable. So this procedure is what we prefer, the flap relift. You can put in a BCL if you feel that the flap is not adhering back, but I don't do that. There's some studies that say that BCL may be counterintuitive. So this is a case where we've decided to recut. So recutting is usually done at a deeper level. It's a very old case. Again, microkeratome had greater variation in the depth. So when we've recut here, we plan to go deeper, but as you see, we will be lifting. Can you shut the lights? So this sliver is actually from the previous flap. So we are not really deeper here. There's been a shearing and we've actually folded on part of the stroma, which was part of the flap. So therefore, it is very important to know the planes. The planes fortunately have become more predictable with the femtosecond laser. You must have an even surface of the stroma before you laser. So this is just unfolding, and then because the surface is fairly smooth and there's really no sliver, it was just a fold, we laser and put this back. Like I said, you must use MMC in all cases of enhancement if you're doing even a small number, small power for surface ablation. And for particularly thin flaps, when you remove the epithelium, you have to take care that the flap folds are not there, and you should try and not breach the flap. You should not go deeper than the flap, because then you'll have definitely more haze. Coming on to SMILE, SMILE has lower enhancement rates. In our experience, it's less than 1%. Peculiarity that you must rule out in SMILE is interface fluid in the early post-op period, because if you have pockets of fluid, that can manifest as shifting myopia. A high pressure and interface fluid, it can give transient myopia in the immediate post-op. That must be ruled out. And like with LASIK, you must know your planes. And like I said, look at the 1 day, 1 month and 1 year OCT. It is so much easier to look at the planes in the earlier part. Though they can be discerned fatally, the discreteness goes away. So knowing planes, these are the planes that you see in SMILE. This is the posterior cut of the lenticule, the anterior or the cap cut, and of course you have the side cut. Whenever we are doing retreatment in SMILE, it comes under some criticism that there is no option of re-SMILE. At present, that is true, but there are many other options available. The simplest option is surface ablation, where you simply remove the epithelium and again do a PRK kind of procedure. However, the risk of haze post PRK, post SMILE is much higher. So you must use MMC again and cold BSS. This is also known to reduce the risk of haze. There are people like Dr. Dan Reinstein who cut the cap at a very deep level, like 140 micron, deeper than that. So you have enough tissue to create a flap above the lenticule. The standard deviation of migration, see the air bubbles migrate to the area of least resistance. So if there is another plane available within 18 microns, they may cross cut each other. So you want to be 18 microns away from any intersecting plane. So if your flap or the top of the lenticule or the cap is at 135 or 140, the epithelium, you have enough space to create a 100 micron flap. 18 microns away from the epithelium and 18 microns away from each possible plane. So this is a thin flap LASIK that can be done. Remember, there is a side cut also there, so you have to use two instruments sometimes to lift the flap which have cuts above it. We actually create a cap at 100 microns. So if we have to do a deeper flap, it would be counterintuitive to the biomechanics. So we use the cap to flap technique of a circle scan. So you have already a plane at the cap level of 100 microns. We have to convert that to a flap. So this is a possibility that you do a side cut and that plane gets converted to a flap. But the diameter of a cap is less than that what is desired for a flap. So you create a lamellar extension. This is the junction cut, because you're not exactly sure that there may be a variation of the depth of the cap. So you give a junction cut to make sure that you meet the cap, a lamellar extension, and then a side cut to convert the cap to a flap. There were 3 patterns that were made: junction going up, junction going down, and junction going up and down. This D pattern was seen to be most effective. So just quickly going over what you see. So here you have a 7.7 cap, and if it's a small treatment, myopic treatment, so this side cut only has been chosen. This side cut only option can also be chosen when you have suction loss. This is the side cut only option. This is the D pattern I was talking about. So you just go in with this, you increase the depth beyond the depth of the cap and simply get a side cut. This is just a short video of the circle. So the 7.7 is being converted to 8.8. So the lamellar cut is causing the extension. This is the inner diameter. So you see that we are creating a junction going from 100 microns to 140. So you are creating that cut to intersect. Just ending with this. So this is how it happens. This is the junction cut, the lamellar extension, and the side cut. And the advantage of this is that unlike a flap relift, this is a fresh cut. So the chances of epithelial ingrowth are not there, which is a real risk post flap relift. Simply laser and you put this back on like a flap. And the results are fairly successful. There are studies going on ReSmile. This is just a simple pop quiz. This is something we've encountered in, actually I've had people across our locations encounter this. This is a patient we are taking up for a femto procedure of SMILE. You see the dark spots that have come in. We had to abort this procedure because there are large dark spots and it's come in even at the second cut. So what has happened here? Why has this happened? This is another case. You see when the PI is coming up, there is a lot of moisture here. This moisture has come in because the patient is masked and the PI is getting fogged. So this is a new complication. This interferes with the laser pattern and can be, and therefore you must tape the mask or unmask your patient's post-refractive surgery. Thank you for your attention.
Thanks a lot, Ritika, for covering in detail the various modalities for enhancement. If Sujata madam is ready and she can just set up her laptop, we'll take a couple of quick questions. There was a lot of initial enthusiasm surrounding extra procedures and their possible potential to reduce incidence of regression. But now, 8 to 10 years on after extra procedures, what is the general consensus and opinion from the panelists? Do you all feel it has any role in reducing regression? Doctor.
I think we at least are, I'm a fence sitter for extra because I think that I don't fully understand the role. Dr. Rohit would be able to possibly regression.
But I think Sheetal published a paper where they looked at two randomized groups of ectasia as thing. I think if you look at ectasia as a fear factor, then probably yes. In a borderline thin corneas, or you feel that I don't think anybody has studied on regression.
And
there was an initial talk about using it for hyperopia, particularly for regression, but we don't have enough cases and experience so as to. Yeah.
And incidence of regression, sir? Any LASIK versus SMILE? Generally, what are you seeing? Any differences? It's almost the same? Same almost. So,
If at all you're using an extra procedure, I feel it's better combined with the PRK rather than SMILE or a flap because the reach of the oxygen to the interface, when there's a cap or a flap in front, it's not so good. I think intuitively, if it's just the epithelium that's debrided and then you do extra, it might be more effective.
And we normally do extra for the borderline topographies, and I feel it's counterintuitive to again do a flap or a SMILE in a borderline topography.
Mostly combine it with the PRK.
thank you so much. So up next we have Dr. Sujata Mohan, a very senior and experienced cornea refractive cataract surgeon who will be talking to us about management of flap mishaps.
Thank you, Shreyas, and I'd like to thank Gitansha for giving me this opportunity once again. So she, when I spoke to her, she said you can talk on anything. So I decided to go for my, we have nice videos on flap striae management. So the flap striae can be broadly divided into micro and macro striae, and they can occur because of various causes. It can be just replacing the flap improperly, or it could be a contraction or desiccation of the flap wrinkling, movement of the flap, or rubbing of the flap. Or we commonly see it more in a nasal versus a superior range, and excessive manipulation. So this case, you can see this striae in the center. The other eye had 6/5 vision, and this patient was able to recognize there was something wrong with his eye, and she had only 6/9. And you can see that I have dilated the pupil. It's best to dilate the pupil because you get good retroillumination, and the striae are mostly in the center. And it's just 1 day old, so there's a simple stretching technique, you just do a perpendicular stretch, use a stiff merosil sponge, and then float the flap into position. Don't worry about a little bit of epithelial defect that you might create, and mainly concentrate on the center area because it's not possible to remove all the striae, but just give whatever is the best. And once you have done this, you can put a bandage contact lens so that the patient is more comfortable, and then you get a very good effect. You can see that the post-op, the first day itself, you can see the striae is reduced significantly, and the patient was 6/6, and then overall we went on to get back a 6/5. So this is again a patient who had a trauma on the third day, or he just rubbed his eyes, and you can see that the flap is shifted out of position, and it's all because he had gone away. It took him a couple of days to come, and by the time the epithelium had grown over the exposed stroma. So this is a tricky situation, because if you just leave it like that, the patient is going to have an epithelial ingrowth. So it's important that we remove, even before we lift the flap, we remove all the epithelial remnants over the stroma which is exposed. And not only that, because the flap is twisted out, the striae are quite dense. And you can see that once I have completely removed it, I have also made a 2 millimeter area of epithelial removal around the margin of the flap. This is to prevent epithelial ingrowth. Now you float the flap into position. You can see that a thick striae, and these striae, the epithelium grows into the striae. So it's important that we remove the epithelium to get the best effect. And so almost 360 degrees removal of striae was done, of the epithelium was done. So, and after that, my technique is only just stretch perpendicularly. You can use, there are various techniques described in literature where you can do ironing, and a simple just using a muzzle hook, wetting it in warm water and then ironing, not using too much of heat has seemed to help in certain cases, but this seems to work for me. I'm just stretching perpendicularly. Just make sure that you float the flap into position. And because I knew this was a very thin flap, I decided to suture this flap. Normally, you really need not do it. I'm using 11-0 nylon sutures in this, and 1-10-0 nylon. It's while suturing, you have to be very careful not to shift the flap, and then applied a bandage contact lens. So this is a post-operative visit, maybe after a week or so. You can see that 10-0 nylon suture still visible. And this patient has almost a 15-year-old follow-up, and I really can't make out which eye had done this procedure. So this is again another patient who had a flap striae. You can see these are quite dense striae, and the epithelium is also disturbed a lot. So again, removing all the epithelium from the base of the striae. And see, in this case, you can see the striae better because I've dilated the pupil. It always helps to dilate the pupil. So you can see the striae better, and they are quite dense striae. The flap is very thin. So if this doesn't work, sometimes you might have to amputate the flap. But in this case, we just went ahead with the stretching technique and sutured the flap, and we had pretty good results. So this was again a traumatic dislocation. You can see that the whole flap is lying on the conjunctiva. So again, meticulous removal of all the epithelium. The flap is scrolled because of the epithelial ingrowth. Again, take care to completely scrape off all the epithelium. You cannot physically see it or clinically see it, but you have to take as much of care as possible to remove all the epithelium. Wash out nicely. And you can use absolute alcohol. That's what I've been doing recently. In this case, I've not used anything. And again, sutured the flap after removing about 2 millimeters of the epithelium all around. This is again a traumatic dislocation, and so again meticulous removal of the epithelium. So the main problem here is not the flap, it's the epithelial ingrowth the patient is going to have after you have put the flap back, and that is going to be a big bugbear to treat. So see here, you can see I'm using absolute alcohol, a 20% alcohol, which we use for devitalizing and using for LASIK. The same thing you can apply on the bed. So what happens is, at least whatever epithelium is remaining behind, which we are not able to see, at least it will not multiply. So that's the idea behind it, because it devitalizes the epithelium, and then only risk is that unless you wash it properly, you can have pretty significant DLK. So the pearls are early intervention, care to avoid epithelial ingrowth, apply a suture if necessary, bandage contact lens. And in late striae, you can use hyperthermic ironing using heated spatulas. And in patients with very severe striae not responding to conventional treatment, you can do a PTK. Okay, I think I'll just stop with this.
Thank you, madam. Very, very interesting videos. As a small caveat, what would you say if, I mean, those large macrostriae, of course, we'll have to remove the epithelium. But microstriae, where patient is presenting a little late, a month later, when they come for a post-op, little vision is defective, 6/9 BCVA. When would you recommend epithelial removal for those type of striae because they are presenting a little late? Would you do it or would you still just stretch?
Yeah, I would do it because I think if they're going to, the rest of their lives, they can't be living with a compromised vision. So if it is in the visual axis and it's compromising the vision, whatever time they're present, we'll have to lift the flap and remove the, definitely epithelial removal. The later the striae they're present, then you really need to remove the epithelium. If there's a striae is in the periphery, then probably you should look for other causes for patient's discontentment. But otherwise, if you can see a clear striae in the center, you must go ahead and do it.
So would it be safe to say that unless it's immediate post-op, whenever the patient presents a little later, you would think of removing epithelium?
Definitely, yes. Thank you. There are striae which are just Bowman's breaks, which you really need not do anything about. But if you see clear radiating striae coming from the hinge, which is the typical description of a striae, then it's better to intervene. Because over a period of time, the patient will start recognizing the difference between one eye to another, and the abrasions will be definitely much better, much worse in the eye which the patient's having striae. So, but it again depends. It's a very, very small, fine striae. It's because of Bowman's breaks. You just leave it alone. But if you see the typical ones which are radiating from the hinge, I think it's better to go in. I would. Yeah.
Sorry, Tanvi, just one second. No, we can continue. If I'll request Dr. Ramurthy just set up his laptop while we can discuss it.
Do you use distilled water while you're before removing the?
No, I'm not. I know there are a lot of reports just using distilled water. I don't. I use just regular BSS. Yeah. Only thing is, I would like to dilate the patient because then it gives us a good glow about glow.
Is there any role of doing it faster because the more you're handling the flap, it becomes more edematous and towards the.
It doesn't matter because I think the handling the flap faster comes only we are going to do a laser ablation because you don't want to dry the bed. It doesn't matter. You can take your own sweet time. And of course, we are going to do it under topical anesthesia. Maybe patient is anxious, you can give him Medoxylum, but you can do it, take your own time.
In fact, you need to give the ironing a fair bit of time. It is not an instant fix. And we use hypotonic solutions. So you mix BSS. And because if you swell up the flap, it's after removing the epithelium, we swell up the flap with hypotonic solutions. If you're using just pure distilled water, it does become more edematous, and then the apposition may be a problem. So we use a 1:1 mixture and continue the ironing for a fair bit.
Also, the challenge is that the striae don't really completely disappear on table, and it's only the next day that they look clearer. So there is no defined or definitive endpoint. So taking some time to ensure sufficient ironing has been done, and that sufficient is how much is sufficient is obviously, I think, case dependent. So thank you so much. Up next we have Dr. Ramurthy, who will be discussing about challenging cases with phakic IOLs.
Thank you. I think we are shifting gears a little bit. I'll be talking about challenging cases with phakic intraocular lenses. First, let me talk about how I exactly do my phakic intraocular lenses now. Basically, there's no dilatation because I believe that the protection that the intact iris offers is significant. And or I make the side ports first just to put in a little bit of saline so as to make the eyeball tense, make my central incision, then inject a little bit of xylocaine with adrenaline combination, non-preserved, that in these young myopes, the pupils dilate very well. And subsequently, I go ahead and introduce a high molecular weight, which is viscoelastic, is usually Helon, and that's the intraocular, the phakic intraocular lens that's being injected, and you make sure that it's opening up in the right way. And essentially, there's no, once I tuck the haptics behind the pupillary margin, there's no need for any irrigation aspiration in these situations, because once I start hydrating the main port as well as the side port, you will find that the whole cohesive viscoelastic tends to flow out as a bolus. And you can see once that viscoelastic starts flowing out, you can see it flowing out through the side ports, then I really am sure that there's no more viscoelastic left. So because of not dilating the pupil and keeping the iris, protecting the anterior surface of the lens, and subsequently not doing any irrigation aspiration, I find that my surgical time is far reduced, and also some of the complications that can be associated with this is also significantly less. This is what you find most often subsequent to your phakic intraocular lens implantation, where there's a very ideal 500 micron vault, as well as the lens is well centered. But then there are some complex situations. I'm going to be dealing with them. Sometimes when your lens is not in position, and this is something you see on the first post-operative day itself, then all I go in with is the irrigation cannula and go through the other side port, and then gently shift the lens. And if I see it on the first post-operative day, I take it up immediately. And it's very rarely that you see this happening few days later. That's very often because of improper sizing of the lens. One thing you need to remember is that the rotation of the lens will only help if the amount of residual error, the spherical equivalent of the amount of residual error, is almost zero. That is, if it's -1 with +2 diopters of cylinder, then rotation of the lens is going to help because it's going to redistribute the power. But if it's just a simple sphere or a cylindrical power, rotation of the lens is not going to have much of an impact, because you're not adding or subtracting any power by rotating these lenses. And then this is a video about cataract which has happened subsequent to a phakic intraocular lens implantation. And only if it's anterior subcapsular cataract, as you see in this case, then you can really blame the lens for it. Very often the cause is a low vault. Sometimes it can be also because of surgical trauma. But as you can see over here, all I do is to make the same 2.8 to 3 millimeter incision, and then subsequently go in with either the front loading forceps or a 10-0 forceps. Just bring out one of the supports of the phakic intraocular lens into the anterior chamber. Then with a hand-over-hand maneuver through the same incision, you can bring this lens out. And because it's a temporal clear corneal incision of just about 2.8 millimeters, it's possible to remove it even with a 2.4 millimeters, both the Indian lenses which are made of hydrophilic acrylic, as well as the Colamer lenses of the Star. And then subsequently you go ahead and very often the concern is that there is a significant anterior subcapsular fibrosis. So sometimes it's a bit of a challenge to get an adequate rhexis, but it's doable, and it's also possible to use a femtosecond laser through the material of the lens to create a capsular rhexis. But that's not really necessary. That's the intraocular lens that has been used. The other factor is use of phakic intraocular lenses in situations of iatrogenic keratoconus or keratoconus after it has stabilized. Supposing once CXL has been done, or because of aging, the cornea is quite stable, you can go ahead and consider this. But please remember, the phakic intraocular lens is only an alternative for glasses. If the patient is going to require hard contact lenses or semi-soft rose scale lenses or scleral contact lenses for visual rehabilitation, such a patient, especially if it's a decentered cone also, is obviously not a candidate for phakic intraocular lens. But if it's a well-centered cone like this, which you could sometimes achieve after a intact procedure, as in this case, as you can see, and the patient is having a best corrected visual acuity of 6.6 or 6.9 with his glasses alone, then this is a patient who do quite well with a phakic intraocular lens. The procedure as such is not much different from what you do in a conventional case, and basically all you have to, this is a fairly old video of mine before I got the Varion overlay. That's the reason you see these markings over there. Most often these patients require high-powered toric and phakic intraocular lenses, and sometimes they can even be custom made to suit the needs of the patient. And usually the rehabilitation is quite good. Of course, you don't promise absolutely metropia, but quite often you are able to debulk both the spherical as well as the cylindrical component quite significantly, and most often make these patients spectacle independent. This is actually a patient who had got LASIK done elsewhere almost 17 years back. Subsequently, 6 years later, developed iatrogenic keratoconus. At that time, we were doing sequential treatment. We did a collagen cross-linkage, then subsequently put a Intex, and a year later did this surgery of implanting a phakic intraocular lens. And this is the post-operative picture, and the patient regained almost 6 uncorrected visual acuity. Of course, this is not the situation in all instances. And this is another case of keratoconus, where you see a single arc has been placed in the eye, and again the cone got reasonably centered. Most important factor being whether the patient is happy with the spectacle correction. If it's contact lenses that is needed, then it's better not to go for phakic intraocular lens or phakic or even toric intraocular lenses, because that may not rehabilitate the patient quite sufficiently. And sometimes even after an excellently done keratoplasty or a DALC, or sometimes it's astigmatism or the residual error, it compromises the results. In these situations, you can of course resort to placing a phakic intraocular lens. You have to be cognizant of the fact that it's a donor epithelium that you're dealing with, and your surgery has to be as gentle as possible and use adequate amount of dispersive viscoelastics to protect the endothelium. Otherwise, the surgery is not much different, and that's almost the end of surgery. So excessive bloating of the incisions is something that needs to be avoided. Way back in 2004, I actually started with iris clip lenses. The results were good, but around 2008 or so, gave it up and shifted over to star ICLs, simply because there was progressive endothelial cell loss even after a well-done iris clip lens. And this is one such patient where she had excellent visual acuity and was quite happy with the visual rehabilitation. But I got my first specular microscope just to follow up on these patients. What we found was that progressively she was dropping her endothelial cell count. It has almost come to 1800. So we actually insisted on her removing the lens, but the patient, because she had very good visual outcome, wanted an alternative. So here actually in both eyes, of course 1 week apart, we are doing the removal of the iris clip lens. It's a PMMA lens, so we need a 6 millimeter incision, and removing the lens and subsequently replacing with a star ICL. We do a significant amount, almost 50% of our cases. We also use the Indian phakic intraocular lenses. They are more cost effective, and I at least in my hands, I find that they also work equally well as the more expensive imported lenses. And this is just the incision being closed down after the removal of the phakic intraocular lens, the iris clip lens, and the star ICL being introduced. Another situation you can see in this, there's a significant amount of nystagmus that is there. Is only a surgical challenge because these patients are highly myopic. Even in these situations, we try to avoid putting in giving any kind of peribulbar anesthesia. And once you get hold of the eye, have some instrument inside, you are able to control the movement of the eye, and it's possible to go ahead and implant a phakic intraocular lens in these cases also. Last of my videos, just a challenging situation where I actually thought it will be a walk in the park case. There's nothing to tell me that is anything different except for the extreme high myopia that this patient had, myopic astigmatism actually. But what happened was, as soon as I started implanting the lens, the cornea literally seems to be giving way. I thought I am doing something wrong. You can see the extreme shallowing of the chamber and the incision actually opening up. And only when I realized that there's something wrong with the cornea. I think it's a brittle cornea that we are dealing with. And when I made the side ports again, they also gave way. And this is perhaps the only phakic intraocular lens case where I had to suture up the incisions. And I am thankful that I did not attempt any laser vision correction because of the suppleness of the cornea. I do not know how exactly the laser vision correction would have functioned in this particular case. Though the surgery doesn't look any elegant, we managed to complete the surgery quite adequately, and the results were so satisfying that the patient insisted on getting the other eye operated the next week, which followed almost exactly the same course with the incisions giving way and the need for suturing up. And this is the 1 week post-operative period. You see there is a significant vault and there's a lot of pigment deposits on the lens, simply because there's quite a bit of handling of the iris. Thank you so much for your kind attention.
Can I request Dr. Rohit Shetty to kindly set up his presentation while we take questions? So, any quick question on sizing for phakic IOLs in keratoconic patients? How would it differ from a normal patient?
Yeah, in keratoconus, the problem is the central area. It's quite deep because you have a central bulge, or sometimes it's eccentric also. So if you go essentially by the AC depth at the central area, you end up getting a slightly larger lens. So in these situations, what we do is to take not only in the center but also in 4 points in the periphery, in the mid periphery, at about 5 to 5.5 millimeters. What we find is that also doesn't work and it's not completely reliable. So when there's significant ectasia, we undersize these lenses by about 0.25 to 0.5 millimeters, and we find that works well. Initially, when we are not doing it but going purely by the AC depth measurement, very often we had the problem of excessive vaulting, and sometimes even the lens capture, in the sense that the edge of the lens gets caught in the pupillary margin. But once we started undersizing these lenses routinely by about 0.25 to 0.5, that seems to work well. Previously we were giving almost a year's time, but now we have reduced it to about 6 months. As far as the visual rehabilitation is good, the patient is comfortable with glasses. We get at least 2 or 3 sequential topographies which seem to be stable. We go ahead and implant a phakic lens.
Just one question. In post-op, you find the vault is low or high. Otherwise, the patient is asymptomatic. Vision is great. So, what are your indications where you want to, do the IPCL or ICL exchange despite patient being asymptomatic? What are the
I think that's a very good question. Previously, we thought 250 to 750 microns is the vault. But Mark Packer in his meta-analysis has shown that even less than 100 microns, there are patients who have crystal clear lenses. I have few slides on that which I even showed yesterday. There's a patient with one eye 80 microns, another eye, the fellow eye 110 microns, following up for almost 7 years. The lens is clear, so we are just following up, not doing anything. On the other hand, we have also had ASOCT proven vault of about more than 1000 microns, but the chamber is open and there's no zippering up, no pigment dispersal in the angles, and the tension is under control. So we go ahead and just follow up these patients. I don't think there's any role for a peripheral iridotomy in these cases with a central hole, but you have to closely follow them up, and over a period of 1 year, if they're quite normal, we just leave them as just follow them up. But if there is a propensity for a little anti-subcapsular cataract, or if you find that the chamber is the angle is narrower than 15 degrees, significant pigment dispersal, then we go ahead and exchange the lens with a smaller lens.
Thank you.
One point would be, at this day and age, if you had to choose between a low vault and high vault, you would rather have a lower vault. With the center of flow, the incidence of cataract is very less. Whereas with a higher vault, you can, in the long term, have potential side effects, goniosynechiae and other issues. And of course, rarely, especially in keratoconic eyes, we've had patients with that optic capture, the pupil tending to slide under the lens, and that creates a lot of photic phenomena for the patients.
So would you be worried of any patient in the sense, with some patients, the STS does not really correlate with the white to white? I have had 2 patients where one I have implanted 13.2, it was a low vault, I had to implant a 13.7. I don't think that they make lenses above that size, but even in that one, the lens rotated. It was a toric lens, it rotated. So the first eye had rotated, so I put a bigger size in the other eye, that rotated too. Now she was a 6'2" height girl, so I probably assumed it to be maybe a physiognomy issue. But are there such cases that, even after doing a white to white, you may still think, okay, it may not be the best?
I absolutely agree with you. I think we still do not have the white to white measurement, and the sizing of the lens is absolutely right. We do not know whether it's a sulcus to sulcus measurement or white to white, what is the exact, but majority of the cases, most lens manufacturers have correlated their sizing of the lenses with the white to white measurement. Usually it's about 1 to 1.2 millimeters more than the horizontal white to white you get. Unfortunately, it works well for most of the cases. Having said that, I've reviewed some of my cases where the lenses rotated. We had done nothing wrong. The sizing had been accurate, everything, and on table, everything seemed to settle down. But since still there is a higher vault or lower vault, and lower vault means more greater tendency for rotation. So I think once in a while you come across these surprises. So even though you feel that you're not doing right, there have been cases when I have increased or decreased the size simply because for that particular case it did not suit well. Fortunately, in these situations, the condition resolved. But it's not very common. I mean, I think thousands of lenses, we have done about 10 or 12 of them.
Would you custom make a lens which is bigger in size?
Yes, it is possible to do that, and extreme myopia, extreme astigmatism, as well as the sizing of the lenses. It's even possible to increase the optic size of the lens depending upon the mesopic pupil that you get.
For the star or only the...
Star doesn't make custom make lenses. It's only the Indian manufacturers who do it for
Both
you.
IOCare and Biotech give you large lenses, customized lenses.
But what do you take for the sizing then, the white to white?
No,
The white to white.
The white to white, because we did a study very recently where we measured 7 different parameters, white to white, sulcostal, different instruments, UBM, ASOCT, and we found the thing which correlates best with outcome is still white to white. And despite whatever advances in imaging we've had recently, so I think we'll have to go ahead. We take with 3 different instruments and we correlate, madam. So we have topolizer and then we have digital caliper. To the extent possible, we ask the optometrist to not look into the reading, but I'm sure they do, and they would adjust the readings accordingly. So I agree, just like all of us would agree, it's still not a perfect science. It is giving at least better ones than 500. What was?
Oh, I think any laser interference biometry, if you use, they don't measure white to white. It's more sulcus to sulcus. It's not limbus to limbus. So usually the science of the instrument is such that they'll give you about 0.3 to 0.5 millimeters more than the conventional topolizers or the calipers. We usually mash them up together, and unless there is a pigment or a blood vessel there in the exactly at 0-180, the topolizer or the op scan gives you fairly accurate readings. And if it lines up with the vernier calipers, then most often you're okay.
Among the 7 devices which we compared, 700, IOL Master 700 was one of them, madam, and it did show a 0.3 to 0.4 millimeter oversizing compared to the other digital caliper and topolizers. 700.
2.8 from the endothelium to that, people.
It's like 2.75.
From here, I'll say yes.
Sorry, we still have 3 speakers left and a keynote address. So without further ado, we're really looking forward to this talk on topo-guided treatment in difficult situations by none other than Dr. Rohit Shetty.
Thank you, Shreyas and Gitansha, for this opportunity. And I'm going to speak on topo-guided treatment in difficult situations. Divided into 2 talks, 2 components. One is for keratoconus and non-keratoconus. So I will, in the interest of time, for 8 minutes, there are different machines we can do these treatments, but I will stick to Schwinn-Amaris platform so that we can discuss more cases. No financial interest in this. Basically, when you look at basics of wavefront imaging, you can look at what is on the cornea, and this is a treatment plan. It basically takes care of the irregularity. But if you're looking at ocular wavefront, it looks at the corneal and also how the lens, in this case, trying to negate the effect of the whole eye and trying to see how it can correct. Basically, when you look at these 2 images, it's of a same patient, graphically represented, but the lens accommodates or tries to reduce a lot of aberrations. So you can see the map is exactly of the same patient, more ablations and less ablations. So in one word, the corneal wavefront versus ocular wavefront does seem to reduce the amount of aberration. The question is it good or bad? It depends on each patient, because reducing the ablation doesn't mean that it's actually correcting this area better. If there's an increased aberration, it does not always mean that your cornea is getting regularized. So this is always a big challenge in understanding of these, making the cornea regular. And these are the techniques, both from the Osiris and like I said, if you're using Alcon, you only have the topolizer, and Bausch & Lomb also gives you the the total abrometry, but it's a Hartmann shack. Very difficult to get a good reliable readings. In this case, these abrometers are pyramidal based systems which are able to get much better readings and more repeatable. So this is what happens when you look at the treatment planning. And the advantage here is that you can compare the profiles of a same patient. If you are looking at the profile, the CW is the corneal, the OW is your ocular wavefront. So when you're looking at any of the laser-based treatments, at one screen you compare, and these new software gives you the ability to pick and choose what aberration you don't need. If you don't want to spend so much of time, you can ask the machine to choose what is the main culprit and ignore what is not. So ultimately, you get a treatment plan which may be completely different, because this is based on what the lens is compensating, and this is based on what the cornea is. If you're looking at a topolizer, you'll probably be doing this. If you're using a Schwinn, probably you look at these two things and you can see, okay, you can see the ablation pattern reduces by half or even more. So virtually, your ability to reach out to patients, more number of patients increases when you are actually comparing these two. The traditionally topo-guided treatment is more on the cornea, but when you increase your range to ocular wavefront with the modern day technologies, then you can actually look at more number of patients being treated. This is again a comparison, and you can see that the ablation depth, and you can see that this is the same patient with much better depth, with minimizing. It's called the minimizing effect, and it creates the changes out here. So why is that minimization effect is it does not treat. Many times we have to understand the cornea also has a lens in our optical system which kind of regularizes a lot of aberration happening. But when you do a topo-guided treatment, say with any of the Alcon platforms, it completely ignores the effect of lens. It only looks at cornea only, which is not a true optical system. The optical system is made of lens and other things, and including the neural factors, which dampens the noise till it reaches the cortex. So this is why it is important that you have to look at both these factors. And when you look at a lot of these patients, you can look at this. If you're just doing corneal wavefront treatment, this machine would correct around 5.5 diopters of coma. It would correct around 0.2 of trefoil and 2 diopters of spherical aberration. This, if you had to correct this, the cornea would burn around 90 microns in the periphery and 24 microns. But when you use an ocular wavefront guided treatment, your ablation drastically drops to 9 microns because the coma has become 1 diopter. That means 4 diopters of coma is completely negated by the lenses. This is a young patient. What happens when he becomes 40, we don't know, because maybe new aberrations will come. But at this point of time, the machine says that 1 diopters of spherical aberration is negated and 4 diopters of spherical coma is negated by the lens itself. The accommodation, the way how the lens takes care is phenomenally good, and you reduce it by 90%. So this is the power of what a total wavefront guided treatment is. And when you start doing, you get these kind of images, and these are again a comparative things which I'll not go. And when you correct it, you can probably get these kind of images out here, which is very important. But there are cases where you use both, there'll be the ablation pattern is very high. And we published this work. This was also a winner, one of the best videos last year. When you look at just doing a small PTK, you can customize. It's called Trek. This is in JRS 2-3 months back. I think it's online. And you can do a long axis, short axis from the topography. And then when you do this ablation pattern with all cross-linking will give you these kind of results. And now we have close to 5 years of follow-up of these patients, and none of them have actually gone for progression. There are other reasons why you need to do it. One is before cataract, if you want to do a zone enlargement. Again, using this is a place where you don't do a ocular wavefront because the lens is already cataractous. So you can just do a topo-guided treatments and then probably do a cataract. Post-LASIK scarring, and this again was published, where this was a patient referred to us with the scar. And we do a lot of these things. You can customize the scar according to where the place is. And you can see that
When you do a PTK on that zone only, it's more like this is what we publish first and use the same principle onto this, and you can do a long and short axis PTK exactly on that zone, so it doesn't really affect the refractive status. And this is the video from there. Just that PTK is just like a coffin placed inside. It doesn't affect any other part of the cornea. It is cyclotorsion compensated, so that you don't have to worry that the laser will fire beyond the scarred zone. And then this is the quality of image, post-op OCT, and we do a lot of these things now. And sometimes we use it for PTK also, exactly recurrent erosion syndrome, where you feel that you don't want to create any changes to the refractive error. It's a phenomenal use of modern machines, especially machines which allow you to do all these changes, completely changes the way you do a customized laser surgery. We know all these factors here, and how does it help is, we call the SCAR TREC. The TREC is topo-guided removal of epithelium. It's more like a PTK, but we use 10 microns more, so that it just shaves off those cornea. Little more sophisticated way of Cretan protocol. And thank you again.
Thank you so much, sir, for the very enlightening talk. And while I request Dr. Praveen Krishna to kindly set up his laptop, sir, challenge has always been, from the days of original wavefront guided treatments, that the measurements are very dynamic, and it's difficult to really have say that the measurements that we are getting and treating based on wavefront can be accurate. How has it changed now in terms of the newer ways of measuring them with the Cirrus and the newer scans available? Why do you feel these are more reliable today?
The machines are more repeatable, the abrometries are more repeatable, and at the end of it, you're not really looking at a complete refractive error correction, you're more regularizing it. So most of the time we correct only the regularization part of it. Me and Garrick have looked at our 12 years data of patients who had follow-up. We got around close to 700 patients who followed up. We could get them on a regular follow for 12 years. Of the 12 years people who had done a laser-based cross-linking, the number of people who had recurrence of regression were less in a topo-guided treatment compared to the one where we had done a conventional cross-linking. So that means SCAR has some way of protecting it, and 90-94% of them did not need contact lenses. They were more of a spectacle independence, which shows that the quality of vision. So 12 years is a long data to prove, and he's just writing this up as a paper. So I'm fully convinced using one of these technologies, I'm more than 99% using one or the other laser forms to correct my keratoconus. Just cross-linking, I just stopped.
Interesting, Rohit. You all started with wavefront with optics, went to topo-guided, going back to wavefront. But in some of these...
Challenge was always not the lasers, the challenge was the machine.
Getting that.
Yeah.
So some of these irregular corneas with corneal scars, etc., getting a reliable wavefront map itself should be
the pyramidal system gives you around 95% of them. 95% of them we are able to, even with highly irregular corneas, you get with this, and we do 3-4 readings of it. And if all readings are matching, only then we plan for the procedure. The newer abrometries are more smarter than what we started with, sir. Even today, if you go back to use your Bauschen lump, it still says image acquisition failed.
What is the lowest fatty? Most of these patients also have...
That's what I said, ma'am. If you're looking at one of the TREC-based techniques where you're using the epithelium plus around 10 microns, with the new thin cornea calculators, I've gone up to 330, 340. And we have 4 years follow-ups of them.
Do you get any scars in these patients?
Very minimal. The reason we don't get scars in very thin corneas is because their keratocytes population is 60% less than the scar happens with keratocytes when become myofibroblasts. That's why you get more in thicker corneas, more healthier corneas, because they are more healthy.
Thank you so much, sir. So we'll move on to Dr. Praveen Krishna's talk. His talk is going to be an enigma. We are not sure what he's going to talk about.
Thanks, Shreyas, and thanks to Gitansha as well, who set up this talk. Well, the ask was to speak about using epithelial maps in refractive surgery and in planning surgery as well. Unfortunately, I don't think we use epithelial maps a lot in planning and executing surgeries at this point of time, and that's why I thought we'll probably talk about something that's a little alternative. So I'm going to be speaking about an alternative for keratoconus. So very quickly, when you speak about the nomogram for handling keratoconus, I'm going to be focusing on severe keratoconus, which are not amenable to do cross-linking. And typically, you start to think about doing a keratoplasty in these patients, and what do you do for these patients as an alternative? So because of the fact that we started to have a title that links to epithelial thickness, I guess the link is the fact that epithelial thickness is known to be lower in the area of the cone, and that's one of the diagnostic measures for diagnosing keratoconus in very early cases as well. So this is the typical case that I'm talking about, somebody who has unaided vision of counting fingers at 1 meter, spectacles 2200, does well with contact lenses but is unwilling to wear them or is probably uncomfortable with them, and also very steep topography, very steep keratometry, and a very thin cornea, 350 microns thereabouts. So there have been alternatives that have been described. One is a Bowman's membrane transplant by the group from Rotterdam that seems to have achieved some amount of flattening and reduction of progression in these patients. There also have been groups from the US who've spoken about Bowman's membrane transplant as well for a marginal improvement in the best spectacle corrected visual acuity. From Spain, there has been stromal lenticular implantation with decellularized stromal lenticules, human corneas, with again marginal improvement in the K values as well as marginal improvement in the visual acuity of these patients. I think the most common use, at least that we've seen in India, has been the implantation of allolenticules from patients who are undergoing SMILE. This again has been proven in rabbits to be something that is viable, and I think we've seen several case series as well as case reports saying that this is a potential technique to increase corneal stromal thickness so that you can cross-link these patients. But it is interesting to see that there are reports of immunological stromal rejection even in these patients if you do not decellularize these corneas. So one of the thought processes that we had then was to try and use a non-cellular implant inside the cornea to see if we can stabilize the cornea. And this comes with work on corneal inlays, which potentially started about 14 years ago. This is an inlay that actually was for refractive correction, and this was an abandoned project because the inlay tended to accumulate a lot of deposits. So we started working with this precision engineering company in Germany, and they have a machine that actually makes our dissect lenticules in our eye bank. And following that, we also started work with them to see if we can use the same kind of technique to correct myopia like a PRK, but not using a laser with only a blade. We had partial success in this measure as well, but this led to also trying to create these kind of lenticules in donor corneas from the eye bank and implant them under a LASIK flap. This is called LIKE, and this is to correct high hyperopia again. So this method seemed to have some success, but again in very high hyperopia. An example of this procedure is in this patient who had +8 correction of hyperopia and did really well with a residual of about +1 diopters and very, very stable over a period of 4 years. That's the lenticle inside. So we tried to apply this idea to a patient who had very severe keratoconus. You can see that the K readings in the range of about 70. This patient had vision of CF 1 meter, refraction of -11, -325, correcting to 2200. He did well with contact lenses, but again, he was intolerant. If you look at the corneal thickness, just below 500 microns was his corneal thickness again. So this is when, along with this company, the porcine collagen lenticule that they had invented was something that we wanted to test out. And this is basically porcine collagen lenticule that is decellularized and is completely devoid of any antigenic stimulus. This is again not novel in humans. They have been used, porcine collagen has been used for cardiac valves, several other areas as well, and most recently xenotransplantation of porcine collagen cornea as well in the case of fungal keratitis. So for this particular patient, we decided that we're going to try and use this lenticule inside the cornea, And again, just looking back at the epithelial thickness, you see that the epithelium is thin over the area of the cone, and you can see this is quite a steep ectatic cornea preoperatively. So the procedure is quite simple. The procedure, this is called Xenia as of now. It is available officially in some test sites, and it includes creating a small corneal pocket within the cornea. This needs to be controlled because these are already very thin corneas, and the epithelial thickness can be variable. And this implant, which again can be customized from the thickness as well as from the diameter, can be injected into the stromal pocket. The stromal pocket, again, we tried creating it using the Visumax, but it seems as if the femtosecond laser by Alcon, the FS200, gave us a more robust and deeper stromal pocket, and it was more easy to implant it in those eyes. So once you put the lenticule inside, this is pre-op pictures, this is 1 month post-op, and this is 8 months post-op. You see it's actually quite clear of the same patient that I showed you preoperatively, and is also quite stable. The pupil is dilated because we also do a fundus evaluation at the time of the patient's visit. On the OCT, you can see that there is significant flattening of the cornea as well from preoperative to postoperative 8 months. And this is again evidenced by the preoperative versus postoperative corneal topography. And you'll see in the center that we've achieved about close to 33 diopters of flattening in the center, which I think is not possible with any other surgical technique at this point of time. So this patient also had very stable topography at 1 month, which seemed to maintain itself, and similar kind of cylinder at the end of 8 months of follow-up, which was last month. Again, interesting because to link epithelial thickness, we found that the epithelial thickness as well had increased compared to the preoperative thin epithelium, had actually become hypertrophic midway at about 3 months, and then at about 8 months seems to have become quite regularized. And you see that the corneal thickness has become about 70 microns thicker, which is the thickness of the lenticule we implanted. Visual acuity, he went from 2200 best corrected to 2060 best corrected, from a -11 to a -0.5 myope. The cylinder is thereabouts in the same range, so really not much change in the cylindrical correction. So this again is a very controlled study. This is approved by the CDSCO only for 5 patients right now, and we have waiting for 1 year follow-up. We have about 8 months of follow-up for these patients. And if you look at the patients uniformly at the 3-month visit, all of them seem to have done well with a significant reduction in the refraction and quite a significant improvement in the visual acuity as well. So this, in summary, is a stromal lenticule implantation to actually fill the gap for patients who are not suitable for cross-linking or any other procedure where vision might not improve, who can't use contact lenses, and the only option is to do a keratoplasty. And it seems to be a simple 10-minute procedure that can be done under topical anesthesia, can be done at the laser, just requires the same skills as you require in laser surgery or SMILE, and actually gives the patient very rapid visual recovery as well. So we hope that this is something that will become part of the algorithm to manage keratoconus in the future. Thank you.
Very interesting, sir. And while I request Rupal Shah madam to kindly set up a laptop. So for any of these tissue additive procedures, apart from volume replacement to also cause the kind of fantastic flattening that you showed, you would have to have them a little thicker in the periphery and thinner in the center. So does Xenia?
Not required. The reason why this seems to work is this is a pre-cross-linked lenticule, and this is also a shaped lenticule. It is not cut according to any curvature. You can actually preset the curvature of the lenticule and ensure it's cross-linked. So it actually is rigid. So once it goes in, it tends to maintain its shape. So even on the OCT, it still was thicker in the center and thinner on the periphery as well. It's the change in the shape because of the rigid cross-linked lenticule that makes the cornea flatter in the center.
Can you do a topo guided after this?
Oh, sure you can. You can do a topo guided on the lenticule before you put it in as well.
Yeah, you should actually do a customization there.
Yeah. Yeah, but since this is part of a clinical trial where that is not part of the protocol, we're just hoping that we complete 1 year without any issues. And once that is done, maybe in the future, the options are limitless.
No, because without that, the volume replacement will definitely cause some flattening, sir. That's
True.
because of the addition of the tissue itself. But like a topo-guided regularization, reducing the tissue, because if we have a thicker periphery, we are likely to have more flattening. The center was what, I mean, that's what we've been taught through our different implants, intracorneal rings and other things, where we create a more mid-peripheral steepening to have a flatter center. Do you think that would be possible in these implants? Or?
I think the mechanics of that is a little different from this one, because there you only have stretching of the periphery and nothing in the center. This is actually something in the center that is physically compressing or flattening the cornea. So I think the mechanics are a little different.
Keratoconus, but more modernized, I suppose.
Well, intrastomal epikeratoconus.
Depends on what depth you put the lenticule at.
It seems as if, again, for the first 3 cases, we used a relatively shallow depth, about 120, like we would do with SMILE. But then we found that the epithelium was not very healthy in those patients. So we went deeper. In the next 2 patients, we were about 150 microns. That seemed to work much better.
And that will possibly be better. Sorry.
I was thinking if it's possible for us, even for those of us who don't have an access to this, can we cross-link a SMILE lenticule and put it inside? Would it work the same way as this?
I think the difference is the fact that, one, this is decellularized. So you will not have any stromal infiltration in this lenticule. In fact, when we looked at confocal 8 months later, there are no cells in it even right now. Second is because you can cross-link a tissue that is outside the human eye as strongly as many times as you want. So this is actually very rigid. It's a custom cross-linking protocol. Whereas our regular cross-linking, I don't think is going to transfer the amount of rigidity that this kind of lenticule will have.
So you don't think it can be done with a human cornea?
I think it can, but I think it's also about supply and demand. I think human corneas, though we have plenty of tissues that potentially can be used, that are not used for keratoplasty, I think eventually it's not going to be a viable market to have that, because we will still be dependent on human tissues. The processing of them is going to destroy quite a few. So I think this porcine lenticule probably is more of a viable implant.
Yeah, is it Keratoconus?
It can be customized. It can be customized based on, it can be also, because this is again cut with a very precision microkeratome, the one that I showed you in the beginning called a nanotome. Depending on the cavity that you actually generate, you can also do a topo-guided lenticule generation as well. So there are limitless possibilities for this in the future.
Thank you so much, sir.
There is a future for a non-organic, meaning, so not a living tissue, but an artificial tissue to do the same thing?
I don't think so, because this again comes from, in 2004 was the inlays that I first showed you. And I think we've had several companies try to put these non-living tissue inside the human cornea. Nobody really has had success, especially with anything that is more than 4 millimeters in diameter. I think Raindrop as well as the camera were the only ones that were successful, but because they had a hole and because they were smaller. Thank you.
Thank you so much, sir. Very interesting talk, and we have 2 speakers left in the final 20 minutes. So, Madam, looking forward to your talk on SMILE tips and tricks.
Thanks, Shreyas. I will make it so lucid that nobody will have any questions. So I'm going to be talking about tips and tricks of improving refractive outcomes in SMILE. Since there is a renewed interest, there are a lot of people now doing SMILE, and also other companies coming up with SMILE-like treatment. I think this is a very relevant thing to learn. So just like any other refractive surgery procedures, the first important thing is to have a proper patient selection. Because unless you have selected your patient properly, you are not going to ultimately get the correct result. So patient selection and counseling, knowing exactly what they want and whether you'll be able to give that outcome is what is going to be the first step in deciding and doing a good SMILE. Coming to the procedure itself, the important step to learn is to do a good centration, because you are going to create a refractive lenticule, and therefore centration here has a lot of meaning. Unlike when you are making a flap, which can be decentered slightly and would not really have a big impact on the final outcome, here centration plays a very big role. For that, it's important that you are checking. So what I do is I don't open the eye till I'm quite close to the contact glass. so that once I open the eye, the patient can have a look at the green blinking light quite easily and is not searching for it. I try and make sure that the green blinking light is right visible to the patient, and there's very little time spent before you do the centration. Just when I have 3/4 of the applanation, I have the suction on, but immediately I check on infrared. If I find that I'm not happy with the centration, you can switch off the suction immediately so that the footprints of the contact glass doesn't become too established. Otherwise, every time you refix, it will go and fix in the same position. So make sure that you are doing it quite quickly and before the suction footprint has achieved its goal. The next step to do, Donald Trump is stuck here, though everywhere else he is not. The next step, important one, is to prevent any suction loss from happening. Because suction loss would not only make you feel uncomfortable, but also the patient. So suction loss prevention can happen only if it is going to be that you are paying full attention to the procedure. Suction losses are not very common because the lasers have become very fast. The suction itself is not really painful, but it's important to give that vocal anesthesia and keep guiding the patient that it is now coming to an end, especially when the second pass starts, because the patient may stop seeing the green blinking light or may see a slight shift or may feel that they are not able to see that clearly. That's the time when you should be prompting to them that that is what is going to be happening, and so nothing to worry. In some ways, if you can keep them occupied, the most times what I do is I ask the patient to think of a very happy moment that they had in life, and you would not believe they spend that entire 25 seconds thinking about what was the happiest moment and don't even realize that the procedure is over. On the other hand, if you try and tell them that find out the most miserable moment that you had in your life, they would have like at least a 25 to be told to you within those 25 seconds. So it's better that you keep them thinking about the happiest moment and let then this procedure be one of the happiest moments for them. It's also good to learn the initial separation because that makes lives very simple when you are trying to extract out the lenticule. So in initial separation, it's important to find both the planes quite early on so that before all the tissues become dry, what most of us do is to create on one side the upper separation and on the other side the lower separation, as you saw here. And then it's very easy because you can make out whether you are in the correct plane or not. It's also a good idea to separate out the complete lenticule so that it's a free floating lenticule inside, and then you don't really need to go in to take it out. You just take it out from the incision site itself, and then you are not disturbing much lamellae. And finally, the free lenticule just needs to come out. So as you can see, the separation is very easy. This is just a simple spatula. You don't even need fancy instruments to do the procedure. Make sure that you don't keep going in and out all the time, because every time there is a potential of taking epithelial cells with you, especially if the person is a little older, because they have tendency for having a slightly freer epithelial tissue. And once you have a complete separation like this, you can just grab it from at the incision site itself. And finally, you should have a good wash and an ironing on top. So I don't like to go inside the pocket as far as possible unless I have done a lot of manipulation inside. But otherwise, giving good wash from outside and hydrating the lamellae is an important thing. And finally, making sure that the incision is sitting well. The eye actually smiles back at you at the end. So thank you very much. I hope I've saved a little time for you.
Thank you so much, madam, for the very lucid talk. And as you mentioned, I don't think people will have questions on how smile is done after this. And So we come to the keynote address of this session, and Dr. Manpreet Kaur, who's an assistant professor at RP Center and has authored 2 books on refractive surgery and smile, along with Dr. Tityal sir, is here to be talking on refractive lenticule exchange extraction, the way forward.
A very good morning to all of you. So I'll be talking about refractive lenticule extraction. Is it the way forward? No financial disclosures. So we have seen the evolution of refractive surgery along the years, from incisional surgery to surface ablation to flap-based corneal ablations, phakic and now refractive lenticule extraction is the latest procedure in the foray. And it was first described in 2007 and received FDA approval in 2016. So what exactly is small incision lenticule extraction? As we all know and we have heard over the past 1.5 hours, it's a femtosecond laser assisted intrastromal refractive lenticule extraction, and now it's approved for a myopia of -1 to -10 diopters and up to 3 diopters of cylinder. So it's a fairly simple procedure that involves femtosecond laser application to create the lenticule bed, lenticule side cut followed by a cap cut and a cap side cut. And it's a fast procedure, 25 to 30 seconds, and then the lenticule is extracted. Conventionally, the anterior plane is dissected first, followed by the posterior plane, and then the lenticule can be extracted via a small 2 to 4 mm side cut incision. The side cut size decreases with increasing surgeon experience, and you don't even need a forceps with time to extract the lenticule. Even when you're dissecting, you can take it out and then just extract it from there. So looks easy, and is it better than LASIK? Ocular surface stability we have seen is much better. There is a lesser damage to the subbasal nerves and faster recovery of the corneal innervation, less post-operative dry eyes. So maybe a better choice for patients who have mild ocular surface disorders pre-operatively but are still motivated to undergo refractive procedure. Then coming to the biomechanical stability, the vertical transection of collagen lamella in strong anterior and peripheral stroma as seen with the flap-based procedures is not there with SMILE. So it is theoretically superior biomechanical stability is seen. However, ectasia has still been reported in cases of SMILE, though less than LASIK. Long-term outcomes we'll know in the next decades. The disadvantage, there is still a learning curve with SMILE. As in LASIK, we have a dictum of see one, do one, and teach one. Does not really hold true for SMILE. There is a surgically challenging learning curve, with majority of complications observed in the initial few cases, including side cut extension and tear, cap tear, suction loss, opaque bubble layer. So the main complication during femtosecond laser application is suction loss, which can be observed at different steps: the lenticule lenticule cut, or the cap cut, cap side cut. So when you have the suction loss during the lenticule cut, as in the case shown above, you have to abandon the procedure and convert into a surface ablation or a flap based. During cap cut, cap side cut, lenticule side cut, you can redock and restart the procedure from the same point at which the loss occurred, and we have an algorithm for the management of suction loss. So now we are fairly confident in managing suction loss in different stages. Then coming to the lenticule dissection part, the main complication observed is a cap lenticular adhesion, wherein you inadvertently dissect the posterior plane first and have a host of complications because of that: retained lenticule, delayed visual recovery, cap and side cut tears, posterior stromal damage, epithelial defect, irregular astigmatism. So now we have various techniques to manage cap lenticular adhesion. ASOCT we have seen is a useful tool to identify that you have indeed gone into a posterior plane. At the anterior plane, the lenticule is stuck to the overlying cap, and then you can use a Sinskey hook to just nudge off the lenticule from the overlying cap and then take it out, peel it off, and extract it by the same side cut. And double crescenting edge separation has been described by us for the management of cap lenticular adhesion in SMILE, in which you can separate the lenticule from the overlying cap from both the edges and separate it till the midline, then take it out, because when you are doing the anterior plane later and peeling off the lenticule manually, there is always a chance that you extend the side cut or induce a cap tear. So slowly peeling off from both edges decreases these risks. Then stepwise management algorithm has been described by us for the difficult identification of correct dissection place in SMILE. So now we are so confident that if we have a cap lenticular adhesion, as in this case, we just go in with the sharp instrument and just nudge off the lenticule from the overlying cap where it is stuck and extend this separation plane to the site of the side cut, and then you can introduce a dissector in the anterior plane and the rest of the dissection is near normal. And you can, in fact, in this case we ended up extracting the lenticule via the same side cut incision without even using a forceps or trying to peel off, doing a lenticulorhexis sort of maneuver. So with time we have managed to overcome these complications that were initially seen as challenges in SMILE. So patient selection, as Dr. Rupal also pointed out, is very important, especially if you're starting out with refractive lenticule extraction, and you should choose patients with thicker lenticules, so a moderate to high refractive error, and more cooperative, no deep set eyes. So prevention, of course, is better than cure, and meniscus sign has been described by us to prevent lenticule misdissection, in which you separate an anterior lamellar channel, then a posterior lamellar channel, and you see a meniscus-shaped sign at the site of cap side cut, and this indicates if the instrument is above or below. Microscope integrated optical coherence tomography has emerged as a useful tool to aid in on-table real-time assessment of the planes. However, it is still not integrated in the SMILE machine, so way to go. So other challenges we have are hyperopia, astigmatism, and retreatment. Hyperopia, we are still awaiting FDA approval. A donut-shaped lenticule with large transition zones are being attempted. Astigmatism, methods for cyclotorsion compensation have been described, including limbal marking, Callisto eye systems. Retreatment, as Dr. Ritika nicely covered, circle pattern, thin plastic, and surface ablation can be done. So is it really the way forward? The outcomes in terms of visual acuity, both SMILE and femtosecond LASIK are comparable. SMILE has advantages over femtosecond LASIK in terms of post-operative corrected distance visual acuity in meta-analysis and less induced aberrations. Newer companies are jumping into the foray, and there are new femtosecond laser platforms for refractive lenticle extraction, including we are now having the VisuMax 800, which takes care of the cyclotorsion and has an inbuilt centration system, decreases the laser cut time, so suction loss should further decrease. Then we have Zymer machine, Femto LDV Z8 laser, and Schweind is also coming up with a new machine. So yes, SMILE is definitely the way forward, and this is our work on SMILE and the current refractive surgery concepts. And I would like to acknowledge my mentor, Professor Jeevan S. Dityal, who has smilingly shown me the way over the years. Thank you.
Thank you so much for that wonderful talk, Dr. Manreet. And we come to the end of this session, and thank you all for having been here and been a part of this session. Thank you to all the speakers and panelists as well.